Good evening. Welcome to the second in our series of BOFAS webinars aimed specifically at registrars. This evening, we're going to be talking about ankle fractures. And ankle fracture fixation has always been our bread and butter. Indeed, the bimalleolar ankle fracture was always considered the training ground for orthopedic registrars. However, how to manage an ankle fracture has always been based on a mixture of experience, tradition, and myth. So tonight, BOFAS Education Committee has chosen this evening's topic and this evening's speakers for their relevance to the topic and for the experience of the speakers, who have both been on a quest to apply science to start to define what makes an ankle fracture unstable. So tonight we're going to talk specifically in two areas, the posterior malleolus fracture and the syndesmosis. Our distinguished speakers are Andy Malloy, Senior Foot and Ankle Consultant and Honorary Senior Clinical Lecturer at the University of Liverpool, and Professor Lyndon Mason, who has been awarded the Hunterian Professorship this year for his distinguished work. Over to Professor Mason.
So thank you for inviting us both up. So my remit has been the syndesmosis aspect of the ankle fracture. Now, start with a new word for the orthopedic lexicon, sequacious. It means someone who follows the opinions of others in a slavish and irrational fashion. So I don't intend to divulge a lot of information now that I expect you to follow irrationally. I'm going to try and provide a lot of evidence. And if you, the evidence is usually with a paper on that side of the screen, all right? Or if I haven't done that, I'll hopefully have given you the reference to go back with. I'll hopefully answer all the questions you've got and maybe asked in your exam. So syndesmosis itself has got a lot of evidence. So if you type in syndesmosis and ankle into PubMed, as you can see, is over 1,000 results. I'll go through the anatomy, the diagnosis, reduction, what implant may you use, and then the post-op. So for the anatomy, you've got the joints, ligaments, biomechanics, stability. So to start with the joint, the syndesmosis is a synovial joint. The synovium itself is it's a hyaline cartilage itself is at the anterior aspect of the ankle. That's because of the way it moves. As you can see by this cadaveric specimen, we have hyaline cartilage here, but nothing at the back. At the back, you have the strong ligament, which is a pivot, okay, because it opens by external rotation. We go into that now. The cartilage is only at the bottom 0.5 to 1 centimeter, and the rest of it is the syndesmosis recess. That goes to about 1.5 centimeters above the joint. In regards to the ligaments, so first of all, you have the ARTFL. This is usually somewhere between 3 and 5 bands, and the cadaveric work that we've done ourselves, most of them do have 3. And 60%, this inferior band here, which got number 3 on, do actually attach to your ATFL. If you have a syndesmotic ligament, don't rule out that they have an ATFL injury as well, even with an ankle fracture. The PTFL, you have a deep portion that attached to the posterior malleolar, which you've just heard from Andy. But also this intermalleolar ligament, don't forget this one, and I'll explain why later on. It's a secondary stabilizer of the syndesmosis. As well as the deep portion of the PITFL, you also have a superficial portion. The superficial portion is seen here. This is some work that we did back last year, looking at the anatomy of the PITFL, and you can see it can go all the way across the back of the tibia. There's some other cadaveric specimens, not from ours. I think these ones are Sesks from London. And the one thing I want you to draw attention to, the interosseous membrane, and this aperture within the interosseous membrane is where the perforating artery from the perineal comes through, and we'll come back to that later. Biomechanics wise, so the fibula itself, it everts and it externally rotates as you go through your the motion. Now, this is one of Karen's paper, who's also one of the panelists today, that when they weight bear, the fibula also rotates out. So this is a comparison between a non-weight bearing CT and a weight bearing CT. And as you can see, the posterior aspect stays a constant length, but the anterior aspect rotates out. Stability-wise, AITFL is the most important rotatory stabilizer. This paper has gone and cut it from front to back and then from back to front, and found that the AITFL, when they start cutting from the front, give you the more stable on rotation. In regards to coronal stability, this only actually made a difference when all the ligaments were gone. So that's the coronal stability is the translation. We'll come back to that when we're talking about the hook test and the external rotation test later on. Sagittal stability, you don't need much in the way of ligament injury to actually have sagittal stability. And sagittal instability is from back to front, so the movement of the fibula from back to front. So if you talk about, well, does the bones make a difference? We talk about the ligaments. The incisura is actually a very shallow cup, so it doesn't really give you much bony stability. This is a paper I've already mentioned with the average surface area type 2B fracture. If you look here, the type 2B, which is the larger bony injury, actually had less syndesmotic instability. And the reason for that is the average area of the PITFL covers the entire back of the tibia, which is much greater than the 2B fracture. So if you have a mainly bony injury, the ligaments are sometimes reserved. But if you do have an injury to the syndesmosis and the posterior malleolar, actually fixing it will give you better stability. And there's 5 papers indicating this. This is another one of our papers looking at the intermalleolar ligament avulsions with the posterior malleolar. And this is what you get. This is the intermalleolar ligament. And in pronation injuries, as the fibula moves in that direction, it does pull off a bit this fragment. So you can see this fragment here. This is some work we've done that we haven't published yet. It was presented in BOFAS last year. That the Wagstaff, which is the footprint of your AITFL, if you have a look at it and compare it to dissection, when we had a look at all our CT scans with the Wagstaff fragment, which is only with 40 of them, they average about 10 millimeters, and the size of the ligament is 21. And only half of them had ligament instability. So if you do have a Wagstaff fracture, it doesn't mean your syndesmosis is unstable. But if it is unstable and you fix that back, you will repair some of that ligament. The diagnosis. So clinically, well, it's difficult with an ankle fracture because it's usually very swollen and very painful all over. But I put these in just for the completion sake. If you get a dorsiflexion external rotation test, it's by far the most sensitive and specific. As you can see, as you're coming down this on this paper, the local tenderness and the squeeze test are either sensitive or specific. But if you add them all in together, you get a much better result, both sensitivity and specificity. There are other examinations, such as a cross-leg test or the ballottable syndesmosis. Radiographic, Andy's already commented on this as the tibio-fibula clear space, which is from A to B, and your tibio-fibula overlap, which is from B to C. As you can see, this is usually less than 6 millimeters, greater than 6 millimeters, and on your mortise view, this goes down to greater than 1 millimeter. But it's very variable. There are papers that show that if you look at the entire population, it is a normal distributed. So you have people who have much wider syndesmosis, which is normal. It's very important to actually x-ray the other side if you've got any concern. This is just to demonstrate on what was a schematic, what it looks like on an x-ray. Intraoperatively, the ones most people know is the hook test and the external rotation test. Now, as you can see, the hook test has a sensitivity of only 25 as compared to the external rotation test of 58. But as I said earlier in regards to stability, for the hook test to work, you have to have 3 ligaments gone. So it would have to be coronally unstable. For external rotation test, you only need 1 ligament to be gone to be rotationally unstable. So the external rotation test, for me, in my practice, is what I use. So as you can see, this is an external rotation test, opening up this medial opening and opening of the tibio-fibula clear space. I won't labor on this. It's also the internal rotation test that Andy's already been through. You can do arthroscopy, and this is in a lot of people seen as the gold standard for testing of syndesmosis. Personally, I went through a period where I scoped all major nerves. I must say I didn't, in my hands, found it not very usable, but there's plenty of centers that use it with great success. As this paper shows that what you're looking for the syndesmotic reduction, you can see AITFL here, and so there's a gap, and there's the fibula to show that you've got posterior translation, and we've got overlap of PITFL. That's why the fibula has been posterior translated. Reduction. So we're going to go through the assessment, how we use the clamp, and other influences. So assessment. So if you're assessing your syndesmosis reduction, you're either assessing it clinically or radiologically. Clinically, the two tests are either to look at it, and this is one you can see as we are looking, and you can see where the fibula, the AITFL tubercle sits underneath where your AITFL footprint, the tibia is, but you can also palpate it. Personally, I usually palpate, and this paper has shown no difference in malreduction, even you palpate or you have a view of it. We've already been through what you're looking for on your AP, but on the lateral, you're looking for the fibula to have an intersection with the posterior plafond, as you can see. Okay. On this paper, only 6% had anterior translation greater than 2 millimeters, so we expect it to be coming through the posterior plafond. How you apply the clamp, there's two good papers on this. This is one of them, where if you predictably put your clamp in between the anterior aspect of the fibula and anterior aspect of the tibia around this region, then this is the perfect area to get a central reduction. This paper actually went further to look at malreductions. You can see there is no malreductions anteriorly displaced if it was on anterior tibia, and there's only very few on the posteriorly displaced on this area. So this is where you're looking for, around this area here. And this is also where you're looking to put your screw. Other influences. So if you have any slope, anterior, posterior, and you put a clamp on, then it will move in that direction. Now, you're not going to know that unless you've got a CT beforehand, which is not really routine for all syndesmotic injuries. The other one is, as we could return again and again to the posterior malleolar fracture. If you have a big posterior malleolar fracture and there's a gap, so not only so if this is moved this way or this way, if there's a gap in between, you will have a gap malreduction. So if you're not fixing these and you just put in a clamp on, especially if they're large, you are a better person than I to get a perfect reduction on these. And Andy's already alluded to this, and you can see this, if you see the posterior malleolar fracture, and so well off like this, the syndesmosis is definitely malreduced. And as you can see, the fibula itself is also sitting not in line with your posterior plafond. So you can know that that fibula is malreduced. And he's already done this. Can you over compress the joint? The answer is yes. I've done this twice, where when you put in the syndesmotic fixation, it spits out your saddle-shaped talus. And this can only happen really if ATFL and deltoid are also damaged. But that can happen. It's happened to me twice, and you put the syndesmotic fixation in and it actually moves forward. This is not one of mine, this is from a different paper. And as you can see, as they removed and revised it, the talus is now sitting in the right position. What implant do you use? So this was a paper from FAI many years ago, and you can see when they asked all the different questions, there was a raft of different answers. But do you position the live screw diastasis screw was relatively on position, and I agree with that. Do you elect to remove the screw? And after, this was over 10 years ago, and they said mostly yes, but we go through why, and so I don't elect to remove mine. What screws? Well, number of screws, number of cortices, size of screw, position of screw. On the cadaveric, radiological, and clinical studies, there's no difference. Okay, this review paper, there's another review paper by James Calder as well, all saying the same thing. There's no difference no matter what you use. Hardware placement. Well, we've already said that the syndesmotic recess is 1.5 centimeters from the joint, and 2 centimeters above the joint is the ideal strength maintenance. That's where you want to keep it for the strongest hold. But also remember, as I talked to you about that area of where the peroneal artery perforated comes through, as you can see, it's coming through here, coming through to the front, to the back of the syndesmosis of the peroneal artery, and the perforated is coming through the front. And it supplies 60% of your anterior ligaments. And also, if you catch it, it's a relatively large artery to actually injure. This is on average 3 centimeters proximal to the joint. This is another one where they looked at the, in comparison to screws, the superior and inferior, and you can see the inferior screw is usually well away from it, but the superior screw can be very close. So in theory, you need to get your implant somewhere between 1 centimeter and 3 centimeters from the joint. Hardware choice. So this is the question between suture button or screw. So cadaverically, a suture button provides a lot less strength than a screw fixation. However, if you compare it to normal walking in a boot or plaster, the 20 nanometers that it requires for this, it doesn't actually reach that point. There's a level 1 meta-analysis come out this year, 7 level 1 RCTs. There's been 1 RCT published after, I'll say that later. And they found that intraoperative inadequate reduction was much more improved by your dynamic fixation. Follow-up inadequate reduction, again, much more in favor of the dynamic fixation over screw fixation. Clinically relevant complications, again, much more in favor of the dynamic fixation. Reoperations, even if you take out the ones that were planned reoperations, again, more commonly in your dynamic fixation did better. The AFAS functional outcomes were much better at every time point. OMAS strangely weren't, but it's close to it. But with the addition of the most recent RCT, that would probably go much again to dynamic fixation. And dorsiflexion, you achieved about 4 degrees greater. This is the most recent paper published in BJJ this year. 5-year outcomes and OMAS are significant throughout. So it's gives you much better outcomes with a tightrope or a suture button fixation as you do for a single screw. But there are times that you can use it and times you can't. So this middle question here is the important one really. Is the fibula length actually stable? So if you fixed it with a plate and then it can't move up and down, so then you can usually use it for rotational stability. However, if you don't fix it, so then it can move up and down and side to side and chronally unstable, then the syndesmosis fixation, as I said with the cadaveric study, is a lot less stable. So this is in keeping, this is not one of mine, it's from the International Orthopedic Journal, which is a good example. You can see that they fixed it even though it was a high fracture, and they're rotationally stable with this tightrope. However, if you've got a posterior malleolar fracture like this one, you can actually fix this fragment back to get your length stability, even with a Mason-nerve fracture, and then put a syndesmotic fixation across. And Andy had a few examples on his cases on that. It's another example. Ankle in position implant insertion. I was trained that you had to really maximally dorsiflex, otherwise you over tightened it. There's 2 cadaveric papers that show there's no difference regardless of ankle range of motion. These are both them 2 papers. So other risks, if you're going straight across your 20 degrees, so coming out the anterior aspect, 10 to 25 degrees is where your saphenous neurovascular bundle are. So if you're putting a suture button there, you have to be very careful. Post-surgery, go through screw removal and weight bearing. So screw removal, there's some people who believe that you have to take the syndesmotic screw out before you start weight bearing. Now that's something, quite an early time to commit someone to another surgery following an ankle fracture and not allow them to weight bear beforehand. This study, be it that it wasn't a level 1 study, but it didn't show any significant difference in clinical outcome if they removed or not. Unrelated to clinical progress, recurrence of diastasis was found if you did remove the screw, however. Removal of screw dorsiflexion, no improvement in dorsiflexion if you remove the screw. Removal of screw and function, so there's 7 studies, there's 1 RCT within that. And no improvement in functional outcomes, no improvement in radiologic outcomes. And some actually studies found that if you retained the screw when it broke, they actually did the best. and you were looking at somewhere between a 10 and 30% syndesmotic screw break-in if it's left in. However, if you do have a malreduction, which this paper said that if they CT'd everyone at 3 months, there was a 30% malreduction rate, and they removed, CT'd at 2 weeks, and they removed them at 3 months, it actually reverted back to a normal reduction in 90%. So if it is malreduced, then removing it can make that better. Complications of screw removal. So this paper showed that there was up to 10% had wound infections afterwards, which 3% had a deep infection, and also recurrent syndesmotic diastasis in 5 to 10%. They found that, I thought this was a pretty good graph that they showed that if you took it out even too early, that's when you had your diastasis. Weight bearing. So there's 2 papers that show that weight bearing from 2 weeks do fine. So if you weight bear your syndesmotic fixation, they all progress to union, no hardware failures. And this one, no difference in radiographic outcomes if they weight bared compared to if they didn't. So to summarize, knowledge of anatomy is very important. Think of the coronal and rotational instability. Flexible fixation where possible. Remove a screw, not necessary. And weight bearing early does seem safe. We will know a lot more of that when the wax trial gets published. Thank you.